Hello and welcome to MK's Review Medical Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we'll look at medical topics in depth. Today we're going to be looking at benign prostatic enlargement. So if you haven't yet subscribed to the channel, please hit the subscribe button, hit the bell notification icon to be receiving notifications every time I post such videos. Drop a like, drop a comment, show some support, grab your piece of paper, grab your pen, and let's go. Remember that when we want to use the term benign prostatic hyperplasia or hypertrophy, when you use this term BPH, you're pretty much referring to a histological diagnosis, because recall that hyperplasia is increase in the cell number, hypertrophy is increase in the cell size, hypertrophy and hyperplasia is increase in the cell size and the cell number. So you can only justify this on your histology, but the right term to use when you're making a clinical diagnosis would actually be benign prostatic enlargement or BPE. So remember that BPE is much more common in older men, and it is actually the most common cause of bladder outlet obstruction in men over the age of 50. What we have actually realized is that the incidence in men between the ages of 60 and 90 is slightly above 50%. Early changes can actually be seen in men around 30 to 40 years. Before we actually move on to talk about benign prostatic enlargement, it is fundamental that you have some basic knowledge of surgical anatomy of the gland. Remember that the prostate gland is actually going to be an accessory gland of the male reproductive system. So it's only found in males, it's not found in females. And the function of this prostate is that it's going to be producing this seminal fluid, which is alkaline in nature. That's obviously going to be nourishing, lubricating, and aiding in the transport of sperms. And in addition to this, the alkaline fluid that is present in the ejaculate is going to cause liquefaction of the seminal plug and also helps in neutralization of the acidic vaginal environment. Remember that the pH in the vagina is acidic. The prostate gland itself is going to be composed of glandular tissue, which is surrounded by fibromuscular stroma. And the prostate is going to be surrounding 3 centimeters of the urethra. 3 important structures are actually noted from the prostate. You have 5 anatomical lobes, 3 types of secreting glands, and of course a capsule. Those are the 3 things that you really need to know. 5 anatomical lobes, 3 types of secreting glands, and capsules. You can also further divide the prostate into 3 zones. You refer to them as McNeil's zones of the prostate. You have the central zone, the transitional zone, as well as the peripheral or the lateral zones. We'll talk about that and I'll show you an image much later on. So speaking of the anatomical lobes, you have one median or medial lobe or one middle lobe. You have 2 lateral lobes. You have 1 anterior lobe and you have 1 posterior lobe. So here you have your anterior lobe. Here you have your median lobe, and of course here you have your ejaculatory duct. You have your lateral lobes here. You have of course your prostatic ducts over there. You have the urethra over there. So as you can see here in this diagram labeled D, you have the different glands that are present in the prostate, which I will mention in the next slide. And here are the other lobes. So the lateral lobe, the posterior lobe, the middle lobes. Remember that you have 2 lateral lobes. You also have an anterior lobe, you have a posterior lobe, and you have a middle or a median lobe. And of course you have the ejaculatory duct and the prostatic urethra right there in the middle. Then you have 3 main types of glands. You have urethral glands, which is what is depicted here. You have submucosal glands, which are what are depicted here. And you have these prostatic glands proper. And remember that the prostatic gland proper is where you have carcinoma of the prostate normally arising from the prostatic glands. So you may be asked this on your MCQs, where do carcinomas originate from? They're going to be originating from the prostatic glands. The prostate also has a capsule. It has a true capsule, which is going to be enclosing all the lobes of the prostate. And this is obviously going to be formed by condensation of the peripheral parts of the gland, and it continues with the stroma of the gland. But sometimes you may have what is referred to as a prostatic sheath or a false capsule, which often blends with the pelvic fascia. Now, this false capsule is only present and it is only formed by compression of the posterior lobe. Like for example, in cases of benign prostatic enlargement or hypertrophy, you get compression of the posterior lobe and it forms a false capsule or prostatic sheath. Then McNeil's prostatic zones, you have a central zone which is right in the center, and you have peripheral zones or lateral zones. usually the CA prostate or prostatic carcinoma is going to be arising from the peripheral zones, whilst the zone that's in between is known as the transitional zone or the periurethral zone. That's where benign prostatic enlargement or benign prostatic hypertrophy usually arises from. And what you need to note is that prostatic carcinoma is going to be developing from the prostatic glands proper, whilst BPH is going to be developing from the submucosal glands. Here is an image to explain everything I have been talking about. So here on the above image here, you can see the anatomical capsule surrounding the prostate. You can see the urethra right in the center. You can see the periurethral tissue, which is a transitional zone, and of course the compressed true prostate, which is pretty much the posterior lobe. So here you have the anterior aspect, you have the posterior aspect, and you have the prostatic urethra over there. And here you have one that's actually drawn in this section. You have a bladder over here. You have, of course, the prostate that is surrounding the urethra. So this is referred to as the prostatic urethra. You have compression of the peripheral zones forming you have the compressed peripheral zones rather of the true prostate. Then of course you have smooth muscle at the neck of the bladder. You also have striated muscle or skeletal muscle at the neck of the urethra here, or just underneath the prostate. You have smooth muscles of the prostate. You have, of course, your anatomical capsule and your hyperplastic periurethral tissue, which can sometimes compress on this urethra and lead to bladder outlet obstruction. And then over here, you have a normal prostate gland depicted here on top, and then you have a nodular prostatic hyperplasia that is shown here. As we can see here, there are a lot of glands that have hypertrophied and hyperplasia that's happening in this prostate gland, and of course it's compressing on the urethra. So what happens in the pathogenesis? So the actual cause of benign prostatic hypertrophy or benign prostatic enlargement is not really known, but it is thought that there are multiple factors that are implicated and multiple hormones have been looked at. And what you really need to note is that the gland is actually going to be influenced by steroid hormones. So I'll get you back to your physiology, and remember that the hypothalamus is going to be pretty much controlling the functioning of the pituitary gland. So the hypothalamus is going to be producing luteinizing hormone releasing hormone that's meant to stimulate the anterior pituitary gland, which is the master endocrine gland, to produce a luteinizing hormone. Now this luteinizing hormone that is produced and released into the bloodstream in turn goes and stimulates the testes, pretty much the Leydig cells, to produce a hormone that is referred to as testosterone. Remember that testosterone is responsible for bringing about the sexual secondary characteristics in a male, and most of this testosterone is going to be converted into a metabolite that's known as dihydrotestosterone. And this dihydrotestosterone is going to be stimulating prostatic hyperplasia. In addition to this, we have noted that estrogen actually has a negative feedback on this axis, which is referred to as the hypothalamic pituitary axis. So the exact mechanism of BPH is actually very unclear, but what is actually very interesting is that BPH is not really seen in men that have been castrated. It's also not even seen in pseudo-hermaphrodites and in people that actually lack the active metabolite of testosterone, which is dihydrotestosterone. And remember that the enzyme that catalyzes the conversion of testosterone into dihydrotestosterone is 5-alpha reductase. And this could be a potentially place where we could actually give a drug that can inhibit this enzyme so that we can use this to symptomatically treat patients with benign prostatic enlargement. Then remember that estrogen also has been implicated in prostatic hyperplasia because in aging men, there's actually a rise in estrogen and a fall in androgen levels. So this imbalance between a rise in estrogen and a fall in androgen levels actually stimulates the enlargement of the prostate. And most of the cellular hyperplasia is going to be happening at the transitional zone, or what is referred to as the periurethral zone. And because this transitional zone actually surrounds the urethra, the hyperplasia can cause increase in the glandular mass, and this can actually compress on the prostatic urethra, resulting in what I refer to as obstructive symptoms. Now, the pathology depends on how the prostate is actually growing. So the prostate may grow into the bladder, it may grow outside the bladder, and there are certain effects that this is actually going to bring about. So remember that BPH is going to be inducing gradual changes in the urinary tract, which result from interaction between the prostatic urethral resistance and the pressure inside of the bladder, what is referred to as an intravesical pressure. So in the urethra may be compressed laterally by the enlarging prostate. It may elongate from about 1.5 inches to about 4 inches. It's also going to show an increase in curvature. The bladder may begin to hypertrophy and show some trabeculations, or there may be some diverticulum that may form. So there may be some circulations that may be seen in the bladder. When we're talking about the ureter and the kidneys, because there is actually a blockage in the outflow of the bladder, there's going to be pressures inside the urinary system, and this backflows back into the ureter, and may cause hydroureter. It may also cause hydronephrosis and eventually may lead to renal failure, an obstructive type of renal failure. So risk factors of benign prostatic enlargement include age, especially in individuals above the age of 50. So in men that are actually much older, every time they visit the primary healthcare facility, you must routinely do a digital rectal examination to assess the state of the prostate in order to rule out benign prostatic enlargement as well as CA prostate. Then hormones have actually been implicated. Remember, a rise in estrogen and a decrease in androgens has been implicated in benign prostatic enlargement. Neoplastic changes also put an individual at risk. So things like fibrosis, adenosis, meiosis, or a fibromyoadenoma. Clinical features may be variable, so symptoms may either be obstructive or they may be irritative. I will give you a list of obstructive symptoms and irritative symptoms in the subsequent slides. And remember that any older man that's going to be presenting with obstructive urinary symptoms, you should suspect BPH, you should suspect CA prostate. You should be able to distinguish between BPH and CA prostate on physical examination, on history, as well as in terms of investigations. And then they may also present with acute urinary retention that obviously is going to develop as a result of a precipitating factor that's going to be aggravating the existing benign prostatic hypertrophy. So it could be some drugs such as alpha-adrenergic drugs, it could be anticholinergic drugs, even psychotropic drugs, alcohol, cold weather, and even infection may precipitate acute urinary retention. You may sometimes get some secondary symptoms, like for example, a high post-void residual volume. This is just simply the volume that remains after someone goes to urinate. And of course, if this volume is high, it may actually provide a good culture media for bacterial growth, and this may lead to urinary tract infections. Stasis of urine can actually promote the formation of bladder stones, which are referred to as bladder calculi. And of course, most seriously, if you have high pressures and chronic retention, this may cause bilateral hydroureter-nephrosis and subsequently lead to post-renal failure. Other symptoms include hematuria from, of course, vesical piles. These are like, you could think of these like hemorrhoids that are present in the bladder. Then, of course, you may also have increased libido, which is later followed by impotence. Obstructive symptoms include urinary hesitance. This is often due to prolonged time required for the detrusor muscles to overcome the increase in urethral resistance because the urethra is being compressed. So the muscle has to generate a much greater force to overcome this resistance. So usually they'll take a while for them to begin to urinate. There's also a decrease in the force of the urinary stream. There is a poor urinary stream due to the compression of the urethra. And of course, there may be other features such as intermittency, terminal dribbling, as well as a sensation of incomplete bladder voiding. So intermittency is when you urinate, stop, then you urinate again, and then stop, then you urinate, and then stop. Then terminal dribbling is where this patient actually goes to urinate and they think that they are done, and then when they put their organ back into their pants, then urine comes out again. So this is going to be happening when the detrusor muscles can no longer maintain the increased pressure required to empty the bladder. Then irritative symptoms include frequency, which is often the earliest and the most commonest symptom, which is obviously due to irritation of the bladder trigone and residual urine in the prostatic, in the post-prostatic pouch, and it may also be due to cystitis. There may be nocturia when patients are asleep. Remember that this cortical inhibition, the cortex normally inhibits the bladder, or rather the urethral tone. So this cortical inhibition is going to decrease and the urethral tone is also going to decrease. So it means that it's going to lead to nocturia. So there is a characteristic feature where these patients actually wake up at night to go to the toilet. Then urgency, which is obviously due to stretching of the internal sphincter by the enlarged gland. So urine is going to trickle and it's going to irritate the prostatic urethra. Then you may get dysuria, which is pain on urination, because there is this high pressure that you're pushing against, so there will be pain. And then of course you may get incontinence, which is obviously a late feature of benign prostatic hypertrophy, when you get these large volumes of residual urine accumulating in the bladder, and they have to overcome the urethral resistance, so you get a type of incontinence that is referred to as overflow incontinence. When you do your physical examination, you may get physical signs that are attributed to BPH, but these tend to be occurring much later in the disease. So when you perform a rectal examination, it's going to be revealing a symmetrically rubbery gland with a smooth surface. So the right and the left lobes are often not discerned, and although asymmetry is common, the consistency of the gland is often soft or firm, depending on whether they are more gland or glandular elements or more fibromuscular elements in the enlargement of the prostate. The seminal vesicles are not usually palpable with the enlarged gland. And of course, if you get irregularities of the prostate when you do your digital rectal examination, things like firm nodules, induration, or generally a hard prostate, then you should suspect that there is prostatic carcinoma, and it is more likely, so investigate for that. Then the size of the gland is actually not proportional to the symptomatology. Remember that sometimes you may get a small gland that may produce a high degree of outflow obstruction, whereas the large glands may actually not even produce any symptoms at all. And the suprapubic region should also be palpated to rule out any grossly distended bladder or any features of acute urinary retention. And then when you examine the abdomen, you may see that there is a distended bladder. Occasionally, you may find a palpable kidney and some flank tenderness that may be as a result of hydronephrosis or pyelonephritis. And then in advanced cases, you may see features of uremia and features of renal failure, such as hypertension, tachycardia, tachypnea that may result from metabolic acidosis and anemia, as well as some neurological changes and uremic fetor, which is this smell of urine on the breath, or this really, really bad breath. Then you may also want to do a urinalysis to look out for any evidence of infection and hematuria. And if hematuria exists, then other causes should be ruled out. So here's how you distinguish between benign prostatic enlargement versus CA prostate on digital rectal examination. So in benign prostatic hypertrophy, the prostate gland is going to be smooth, it's going to be palpable, it's going to be rubbery, and you can actually feel the sulcus, the median sulcus. Then the CA prostate is going to be hard and it's going to be irregular. So some diagnostic investigations that you may want to do: you may do a urine microscopy culture insensitivity to rule out any infections and UTIs. You want to do a serum urea electrolytes and creatinine levels to check for any evidence of renal insufficiency. You want to order for a full blood count to check for anemia, because in view of the renal failure, remember that the kidneys do produce erythropoietin, which is needed for synthesis of red blood cells. You may also do a prostatic specific antigen to rule out CA prostate. A rise that is greater than 10 nanograms per mil is significant. Remember that the normal value is around 4 nanograms per mil. And this is actually a bit more specific as compared to acid phosphatase, which is an enzyme that is found in many human tissues. It's also concentrated in the prostate, though it's not really specific to the prostate. You may order a kidney, ureter, and bladder x-ray to rule out any stones which may have formed due to stasis. You may do an intravenous urogram and a kidney, ureter, and bladder ultrasound to check for any hydronephrosis, hydroureter. You may also assess the residual urine as well as presence of any diverticuli. Then you may also do a residual volume measurement. So the patient is going to empty the bladder, then you catheterize them, and normally the residual urine should be around 30 mils. So if the residual urine is actually greater than 100 mils, that would be a significant failure of the bladder to completely empty. You may do a cystoscopy, which can be done to evaluate benign prostatic hypertrophy prior to you performing transurethral resection of the prostate. It's going to be including evacuation of the ureteric orifices, to note any presence of bladder tumors or bladder stones, to note the size, the length of the prostate, and the condition of the urethra. You may also do urodynamic studies where you check for your urinary flow rate, and a flow rate that is going to be less than 10 mils per second is going to be evident of bladder outlet obstruction, benign prostatic hypertrophy, detrusor instability, neuropathic bladder, which may be due to diabetes, Parkinsonism, Alzheimer's disease, cerebrovascular accidents, or neurosyphilis, just to mention a few causes. Medical treatment. So when it comes to treatment, it can be divided into two halves: medical management and surgical management. So the whole goal of medical management is pretty much to relax the smooth muscle of the prostate and the bladder neck, or to induce regression of the cellular hyperplasia and therefore increasing or enhancing the urinary outflow from the bladder to the urethra. So we can actually give drugs for this. You may give alpha blocking adrenergic receptors that are going to be producing smooth muscle relaxation of the prostate and the bladder neck. And one of the side effects of these drugs, such as terazosin and tamsulosin, is postural hypotension. So when the patient actually stands up, they may actually feel hypotensive. They may actually even pass out. This is common in 2 to 8% of patients. So tamsulosin 400 micrograms orally once a day can be given, and it's useful in small prostates that are causing obstructive uropathy, which is due to BPH. Prostatic hyperplasia can also be treated with a 5-alpha reductase inhibitor such as finasteride that blocks the conversion of testosterone to dihydrotestosterone without lowering the levels of the circulating testosterone. Then the effectiveness of these 5-alpha reductase inhibitors is less than half that which is seen in the alpha blockers, but it's useful in big prostates causing obstructive uropathies. And both drugs are actually supposed to be taken for 6 months to a year to actually see any significant effects. So therefore, there is need to follow up this patient in case they may actually go into acute urinary retention. So finasteride 5 milligrams daily, and you may review the treatment at 3 to 6 months and every 6 months to 12 months. They may actually require several months of treatment before they actually get any benefits from these drugs. Other medical interventions include intermittent self-catheterization, transurethral balloon dilatation of the prostate, microwave hyperthermic prostatic therapy, prostatic urethral stents. You may also do transurethral needle ablation as well as high-intensity focused ultrasounds. Surgical management obviously is done to relieve the obstruction when the medical therapy fails. So some indications include failed medical therapy, complications that are present such as bleeding, hydronephrosis, uremia, bladder calculi, urinary sepsis, acute and or chronic urinary retention, post-void residual volume that is greater than 100 mils, that may be significant of failure of the bladder to completely empty, acute urinary retention, chronic urinary retention with overflow dribbling, gross hematuria on more than one occasion, recurrent urinary tract infections, and of course patients that request for restoration of normal voiding pattern because of excessive nocturia or dribbling. So some procedures can be done so that you could actually do an open method or a closed method. The closed method is actually the preferred choice of treatment. So the open method is where you perform a prostatectomy. The hospital stay is much longer, so they stay for about 10 days in hospital. It is limited for patients with extremely large glands that are not really suitable for a transurethral resection of the prostate because the gland size and the time required for resection would be very huge, and there's a greater risk of blood loss and a higher morbidity and mortality risk because of course you're going to put this patient to sleep, so they are going to go to operation theater. Then you may get the majority having a good quality of life after the prostatectomy. And then of course closed method, which is more preferred, you may perform what is known as a transurethral resection of the prostate. I will show you the steps of how it's done, a general overview in the next slides. And of course the hospital stay is much shorter, about 5 days, and the adenomatous portion of the prostate is actually removed via a rectoscope using electrocautery from within the prostatic urethra. So the open methods can actually be done via different routes. You may do it via the transcervical prostatectomy, which is known as the Wilson-Hay procedure. You may perform a retropubic prostalectomy, which is the Millen procedure. You may perform a perineal prostalectomy, or prostatectomy rather, which is the Young procedure, which is not really practiced to date. So the procedure of choice is going to be a transurethral resection of the prostate. So the patient is actually going to be placed in lithotomy position. Then the resectoscope, not the rectoscope. If I said rectoscope earlier on, I meant to say resectoscope. So the resectoscope is going to be introduced via the urethra into the bladder, and of course the occlusive prostate tissue is going to be identified, and under direct vision the tissue is going to be shaved away using this electrified wire loop. And then of course, as the bladder is constantly irrigated with this non-electrolytic isotonic solution containing sorbitol and glycine, extravasated blood and tissue fragments are going to be evacuated. So you also, after this procedure, you're going to be placing an indwelling catheter that's going to be left in place for about 1 to 7 days. Here is an image of how it is actually done. So your prostatic surgery. So in A here, you have your transurethral resection of the prostate. Then you have portions of the prostate that are going to be removed at the bladder opening. And then here at B, you have your transurethral incision of the prostate, and 1 or 2 incisions actually made on the prostate to reduce the pressure on the urethra. So you can actually so here you have an enlarged prostate that's being cut, and then of course the sites of incision of course noted there. So post-operative care, you may establish continuous drainage with normal saline. You may have high output urine. Ensure that you have some high output urine, so oral fluids and IV fluids. You should have some early ambulation to avoid any DVTs and hypostatic pneumonias. Complications include early complications, intermediate complications, and late complications. Early complications include hemorrhage, which is can be due to the clot retention. You may have bladder tamponade. This is obviously an emergency, so you should insert a 22 or 24 G catheter to decompress. You may also get hyponatremic, hypochloremic metabolic acidosis, which is known as a transurethral resection of the prostate syndrome, which is due to absorption of the irrigation fluid that's going to be containing sorbitol or glycine via the venous sinuses. This may cause hyponatremia and metabolic acidosis in 2% of the patients. Intermediate complications include infections such as UTIs and broad-spectrum antibiotics, incontinence of urine, so physio may be needed, and you may also investigate for damage to the internal urethral sphincter. Then, of course, late complications include urethral strictures, renal failure, sterility, which may be as a result of retrograde ejaculation, impotency, as well as bladder neck contractures. Thank you for spending your time to listen to this review lecture video on benign prostatic enlargement. If you learned a lot, drop a like to help me with the YouTube algorithm, drop a comment below, hit the bell notification icon, and subscribe to the channel as well. Share the page to someone who you think may benefit from these review lecture videos. My name is Dr. Moses Kazevu. To Zambia.